Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be doing the quick discussion of this quiz questions related to the nephrology. So the first question is, we have 65-year-old man with vomiting and as well as diarrhea, presenting with hypotension where the blood pressure is 84/50 and as well as oliguria where the urine output is less than 300 ml per day. And laboratory investigation shows blood urea nitrogen of 60 milligrams per deciliter and creatinine of 2 milligrams per deciliter, urine sodium of 10 milliequivalents per liter and fraction excretion of sodium less than 1%. After 1 liter IV saline, the urine output improves, which findings confirm it is the prerenal cause of the acute kidney injury. So, if you see in this particular question, the options like the high urine osmolarity, muddy brown granular cast on urine analysis, FeNA more than 2% and persistent oliguria after the fluids. So, one of the very important etiology which is like the responsible for development of prerenal type of acute kidney injury is the hypotension causing hypoperfusion of the kidney. And in case of prerenal, the FeNA value will be less than 2%, and in patients with prerenal, what will happen to the urine output? It will be reduced and there will be high urine osmolality in patients with prerenal type of acute kidney injury, right? Whereas the presence of muddy brown granular cast on the urine analysis and as well as FeNA more than 2%, this is suggestive of intrinsic type of acute kidney injury, right? This is suggestive of intrinsic type of acute kidney injury. And persistent oliguria after fluids, that is also suggestive of intrinsic type of acute kidney injury, whereas in case of prerenal, once you give IV fluids, then the oliguria, it improves. So that is what is your first question, right? If you see the second question, a 58-year-old diabetic man develops acute kidney injury after septic shock requiring vasopressors. He now enters the polyuric phase after 4 to 5 liters after producing 4 to 5 liters per day of dilute urine. Lab shows the sodium 128, potassium 2.9, creatinine 3 milligrams per deciliter. What is the most appropriate next management or next step in the management of this individual? Fluid restriction to prevent the overload, careful electrolyte monitoring and isotonic fluid replacement, start dialysis immediately, high dose furosemide infusion. So this particular patient is in a state of the septic shock and he is in polyuric phase. What is important in this patient among these options? It is the careful electrolyte monitoring and the isotonic fluid replacement. That is the immediate next step, okay? Because polyuric phase of acute tubular necrosis, right? During recovering, the problem is the tubules cannot reabsorb the sodium and as well as water. There will be massive electrolyte losses, right? There will be electrolyte loss like sodium and there will be electrolyte loss like the potassium as well. So replacing that fluid and electrolytes carefully until the tubular function normalizes is very, very important. And what about fluid restriction to prevent the overload? In the polyuric phase, large urine losses causes dehydration and electrolyte loss. Restriction, it worsens this. So never you should do restriction. Start dialysis immediately. So the dialysis is done only in refractory electrolyte derangements or uremia whenever it develops. Not in routine cases, we don't start dialysis. And high dose furosemide, the individual is already in the polyuric phase and diuretics will worsen the volume and as well as electrolyte depletion. That is the reason why your fourth option, the high dose furosemide infusion, should not be done in this patient, right? Next question. A 35-year-old man is found unconscious after a marathon. He has muscle pain, dark urine and as well as oliguria. Urine dipstick is positive for blood but microscopy shows no RBCs. Labs show potassium of 6.1 milliequivalent per liter, phosphate levels are elevated and there is hypocalcemia. Creatinine kinase is 12,000 units per liter. What is the most initial management in this patient, right? Or what is the most important initial management step in this patient? Mannitol diuresis, alkalinization of urine with bicarbonate, immediate hemodialysis, aggressive IV fluids with the isotonic saline. See, what is this patient developed? This particular patient have developed myoglobin induced tubular injury, right? So myoglobin induced tubular injury. Now this myoglobin induced tubular injury, now what is the cause for this myoglobin being released? That is because of the marathon. And this myoglobin induced tubular injury is associated with myoglobinuria, and that is the reason why this patient is having the dark urine. Now what is the primary treatment here is you need to ensure that this myoglobin is completely excreted out. So you need to give aggressive IV fluids with isotonic saline that will help in washing out this myoglobin. And what about the other options? You take mannitol diuresis. Mannitol diuresis, historically it is used to promote the diuresis, but it has unproven benefit. It is not of very much benefit in case of the diuresis of the myoglobin. Next is alkalinization of the urine with bicarbonate. See, this alkalinization of the urine with bicarbonate can reduce myoglobin precipitation, but only after volume resuscitation, and this is not the first step. The first step is aggressive IV fluids with isotonic saline. And when will you do hemodialysis? When the individual is refractory to medical management, or refractory hyperkalemia, refractory acidosis, or if the individual has uremia, then you do dialysis. So dialysis is not the initial management. So the answer in this question is aggressive IV fluids with isotonic saline. Next question, if you see, we have a 72-year-old man with congestive heart failure. The ejection fraction is around 30% and he is admitted for worsening dyspnea and edema. After IV furosemide, his creatinine rises from 1.4 to 2.2 milligrams per deciliter while urine output improves. Which of the following best describes this condition? So this patient is having the congestive heart failure with ejection fraction of 30%. Now he got admitted with dyspnea and as well as edema. After furosemide, his creatinine stepped up. So what condition we consider this as? See, type 1 cardiorenal syndrome, type 2, type 3 and type 5 cardiorenal syndrome. So this particular patient comes under type 2 cardiorenal syndrome. Now if you take the various types of the cardiorenal syndrome, what is type 1? See, this patient is not having the acute left ventricular failure right now. The patient already has a congestive heart failure where the ejection fraction is like 30%. Now he presented with edema and as well as dyspnea. So it is not the acute heart failure, it is the chronic heart failure. What is type 1? Acute heart failure causing acute kidney injury. Type 2, chronic heart failure causing chronic kidney disease. Whereas your type 3, acute kidney injury causing the cardiac dysfunction. And what is your type 4? Type 4 is chronic kidney disease causing the cardiac dysfunction. And type 5, it is the systemic diseases causing the renal dysfunction. So this will be the various types of the cardiorenal syndrome. So in our question, the patient is already having the heart failure, now developing renal impairment. So it is chronic heart failure causing chronic kidney disease, which comes under your type 2 cardiorenal syndrome. The next question is, we have a 68-year-old man with chronic kidney disease undergoes coronary angiography. After 48 hours, the creatinine rises to 3.1 milligram per deciliter with fraction excretion of sodium less than 1%. And there is bland urine sediment and no proteinuria. What is the mechanism of his renal injury? Tubular epithelial toxicity and renal vasoconstriction, immune-mediated interstitial nephritis, glomerular immune complex deposition, obstruction from the crystal precipitation. So after coronary angiography, there is increase in serum creatinine. What is this considered as? This is considered as the contrast-induced nephropathy. So in case of contrast-induced nephropathy, you have the contrast material. That contrast, it is what is associated with tubular epithelial toxicity and renal vasoconstriction, right? Tubular epithelial toxicity and renal vasoconstriction. And this contrast induced nephropathy, right, it occurs 24 to 72 hours after the exposure to contrast. This will cause direct tubular toxicity and ischemia will be there from vasoconstriction. And how can you prevent this contrast induced nephropathy is you need to do, right, you need to give proper hydration. That is very, very important. And next important is we need to use only lower isoosmolar contrast, not high osmolar contrast. And at the same time, you need to avoid the NSAIDs or the metformin. Okay, you need to avoid NSAIDs and metformin because they are nephrotoxic. And what is the drug of choice? Drug of choice will be N-acetylcysteine. So the answer here is tubular epithelial toxicity and renal vasoconstriction causing ischemia. Next question. We have a 55-year-old man with chronic kidney disease, stage 4, presents with fatigue and pallor. And hemoglobin is 8.9 milligrams per deciliter, mean corpuscular volume is 90 femtoliters, ferritin levels are 250 nanograms per ml, and erythropoietin levels are reduced. Creatinine is 4.2 milligrams per deciliter. Which of the following is the most likely cause of anemia in this patient? The options are decreased erythropoietin production by peritubular fibroblast, iron deficiency from chronic blood loss, vitamin B12 deficiency, and chronic inflammation decreasing the iron absorption. So in case of chronic kidney disease, there are multiple etiologies which will be responsible for the development of the anemia. But out of all these, the most likely cause of his anemia will be decreased erythropoietin production by peritubular fibroblast. And apart from that, anemia could be due to vitamin B12 deficiency, anemia could be due to folic acid deficiency, or anemia could be due to bone marrow suppression also. But the primary cause for the development of anemia in a patient with chronic kidney disease is decreased erythropoietin production. So what is the treatment that you need to give in these individuals is, we need to give erythropoietin supplements. These erythropoietin supplements are epoetin alpha and then darbepoetin alpha, right? Epoetin alpha and then darbepoetin alpha. So this is about the treatment of anemia secondary to erythropoietin deficiency. They have to be given subcutaneously, and twice weekly you need to give this epoetin alpha and as well as the darbepoetin alpha. The adverse effect associated with these drugs will be hypertension, where the individual will present with headache. So this is about anemia. Next question, if you see, we have a 48-year-old man with chronic kidney disease stage 5 with bone pain and pruritus. So if you take the labs, the calcium is 7.6 milligrams per deciliter and phosphate is 6.5 milligram per deciliter. And parathormone is 880 picograms per ml, which is elevated, and vitamin D levels are low. Which of the following explains the initial biochemical abnormality? The options are parathyroid adenoma, second option excess calcium supplementation causing phosphate retention, third option decreased 1-alpha hydroxylase activity, low calcitriol causing hypocalcemia, increased fibroblastic growth factor suppressing the parathormone. So in patients with chronic kidney disease, there will be decrease in 1-alpha hydroxylase activity, because your proximal convoluted tubule is the place where you have 1-alpha hydroxylase, and in chronic kidney disease, your PCT is damaged. So 1-alpha hydroxylase levels are reduced, and thereby there is decrease in calcitriol, and that is the one which is causing hypocalcemia. And hypocalcemia is the one which will increase the parathormone levels, and that is called secondary hyperparathyroidism. That is called as secondary hyperparathyroidism. And parathyroid adenoma, it is the one which will be causing primary hyperparathyroidism, which is not observed in this patient, okay? Because in case of parathyroid adenoma, you will not have hypocalcemia, you will have hypercalcemia, and hypophosphatemia will be there in parathyroid adenoma. But this patient is having hypocalcemia and hyperphosphatemia. Which could be what could be the reason for hypocalcemia and hyperphosphatemia? That is because of chronic kidney disease. And why there is increase in parathormone? That is, decrease in the calcium is the one which will increase the parathormone levels, okay? And so your first option wrong, second option wrong. And what about the fourth option? So if you see this increased fibroblast growth factor 23 suppressing the parathormone, in CKD, the fibroblast growth factor 23 rises early to dump the phosphate and suppress the calcitriol, but does not suppress the parathormone in advanced chronic kidney disease. So in our patient, the parathormone levels are elevated, but this increased fibroblast growth factor will cause the suppression of the parathormone, right? So that is the reason why fourth option is incorrect. Then you take the next question. 63-year-old man with chronic kidney disease stage 4 is started on metformin and enoxaparin post-MI. He develops lactic acidosis and bleeding. Which explains this complication? The options are accumulation of renally cleared drugs due to decreased GFR, enhanced hepatic clearance of the drugs, autoimmune drug reaction, then overestimation of renal function by the serum creatinine. So basically the entire problem is mainly because of the metformin. Metformin is associated with B12 deficiency and lactic acidosis. Now, in patients, if the GFR is less than 30, you should stop metformin. Otherwise, lactic acidosis will get precipitated. And what is the cause of lactic acidosis here? Because there is GFR of 25, this metformin, it is accumulated in the kidneys and it is not cleared. And that is what is responsible for the development of lactic acidosis. So, accumulation of renally cleared drugs due to reduced GFR. This is what is responsible for lactic acidosis in this patient. And many drugs accumulate in the CKD like metformin, low molecular weight heparin, digoxin, aminoglycosides. But in the clinical scenario, what is the drug which is causing lactic acidosis? It is your metformin. So always you need to adjust the dose by GFR, but not by the serum creatinine, right? Next question. We have a 60-year-old man with CKD stage 3 presents with a rapid creatinine rise, that is from 2.1 to 5.8 milligrams per deciliter in 3 weeks. And hematuria is present with the RBC cast. and the C Anka is positive, what is the most appropriate initial management in this patient? So C Anka is positive. What is it suggestive of? This is suggestive of the Wegener's granulomatosis, right? So in case of Wegener's granulomatosis, it is a small vessel vasculitis. You see the options. High dose diuretics to improve the GFR, IV methylprednisolone pulse followed by cyclophosphamide, ACE inhibitor initiation, erythropoietin plus iron therapy. So Wegener's granulomatosis, which is a small vessel vasculitis, what is that you should give is intravenous methylprednisolone pulse followed by cyclophosphamide, right? Intravenous methylprednisolone pulse followed by cyclophosphamide. So this is what is the treatment in case of the Wegener's granulomatosis, right? And why are you considering Wegener's granulomatosis? Because C Anka is positive. This C Anka is being positive. So another name for this Wegener's granulomatosis is granulomatosis with polyangiitis. And this granulomatosis with polyangiitis, it is associated with the development of chronic kidney disease. And these patients require urgent immunosuppression, and that can salvage the renal function. Next question. So we have a 55-year-old man with CKD stage 5. This patient presents with dyspnea, potassium of 6.5 milliequivalents per liter, metabolic acidosis where the pH is 7.15. There is pericardial rub and as well as vomiting. And what is the most appropriate next step in this patient? Immediate hemodialysis, oral sodium bicarbonate and furosemide, start erythropoietin therapy, fluid restriction and the conservative management. So this particular patient is having the pericardial rub. In a background scenario of the chronic kidney disease, there is a pericardial rub. So what is this suggestive of? This is suggestive of the uremic pericarditis. So this is a patient who requires immediate hemodialysis. So absolute dialysis indications, what are these? That includes refractory acidosis, refractory hyperkalemia, drug intoxication, and fluid overload. That is refractory pulmonary edema, not having adequate response for the fluid restriction and as well as the furosemide. Then uremic symptoms like uremic encephalopathy, uremic pericarditis, and as well as uremic gastroparesis. These are the absolute indications for dialysis, right? And the next question, if you see, we have a 6-year-old boy presenting with periorbital puffiness. And this particular patient is also having a frothy urine and pedal edema. Blood pressure, if you see, it is by 100 by 60 millimeters of mercury, and the urine protein is 4+. And there is no hematuria. The serum albumin is 2.1 grams per deciliter. Cholesterol is around 340 milligrams per deciliter and renal function is normal. Which of the following finding is expected on the renal biopsy? So this is a 6-year-old boy having the features of nephrotic syndrome. So what is it suggestive of? This is suggestive of minimal change disease. And you see the options. Subendothelial immune deposits and wire loop appearance. This is suggestive of lupus nephritis, not minimal change disease. Subepithelial spike and dome appearance on the electron microscopy. What is this suggestive of? This is suggestive of membranous glomerulonephritis, not minimal change disease. Mesangial hypercellularity with IgA deposition. What is this suggestive of? This is suggestive of the IgA nephropathy, but not minimal change disease. Normal light microscopy and effacement of the food process on electron microscopy. This is what is suggestive of your minimal change disease, and in minimal change disease, the drug of choice is prednisolone. So here the answer is normal light microscopy, and electron microscopy will show you that there is effacement of the food process, right? Next question. We have a 32-year-old man with HIV infection presenting with nephrotic range proteinuria, and there is mild renal dysfunction. Renal biopsy shows segmental sclerosis and collapse of the glomerular tuft with podocyte hypertrophy. Which of the following statement is true? So HIV infection, and there is segmental sclerosis and collapse of the glomerular tuft, and there is podocyte hypertrophy. And proteinuria is nephrotic range proteinuria. So this HIV, it causes focal segmental glomerulosclerosis. That will be the renal abnormality in HIV. You see the options. It responds well to steroids in most cases. It is associated with high risk of the progression to end-stage renal disease. It's a benign reversible course with ART. Typically shows subepithelial immune deposits. So this particular individual has developed focal segmental glomerulosclerosis. And these patients with FSGS, they are associated with high risk of progression to end-stage renal disease. And this focal segmental glomerulosclerosis, what is a variant that you have in HIV is, this particular variant, it is called as the collapsing variant, where there will be rapid decline in the renal function. And these patients, they also will have a poor steroid response. Because they have the poor steroid response, they are associated with high risk of progression to the end-stage renal disease, right? And what about first option? It responds well to steroids in the most cases. So FSGS patients secondary to HIV, they don't respond to steroids. Okay, so steroids are not mainstay. What is the mainstay? Antiretroviral therapy and ACE inhibitors are the key in the treatment. Second option. Yeah, high risk of progression to end-stage renal disease, that is a correct answer. And it's a benign reversible course with the ART. Remember, it is not having a benign course. It has a malignant course and it is reversible with ART, right? ART slows the progression of the FSGS, but it rarely reverses the HIV-associated nephropathy, right? So the reversibility is not very common. Typically shows subepithelial immune deposits. Presence of subepithelial immune deposits, these are the features of membranous glomerulonephritis, right? So the answer here is the second option. Then we have a 48-year-old man presents with nephrotic syndrome and mild hematuria. There is no diabetes, normal complement levels. Renal biopsy shows glomerular basement membrane thickening with subepithelial deposits where there is spike and dome appearance. Which of the following antibody is most likely positive? So 48-year man, nephrotic range proteinuria, no diabetes, normal complement levels, but subepithelial deposits are giving you spike and dome appearance. So which of the following antibody is most likely positive? Anti-myeloperoxidase antibody, then anti-PLA2 receptor antibody, anti-dsDNA antibody, anti-GBM antibody. So the antibody that you have, what is this basically? This is a clinical scenario suggestive of membranous glomerulonephritis. And this membranous glomerulonephritis, it is caused by anti-PLA2 antibody. That is your primary membranous glomerulonephritis. And this membranous glomerulonephritis, it can be even secondary also. The secondary causes include the SLE, hepatitis B infection, malignancy, and then certain drugs. So this is about the antibody, that is anti-PLA2 receptor antibody. Then we have anti-myeloperoxidase antibody. Anti-myeloperoxidase antibody is your p-ANCA. This p-ANCA, it is positive in case of the microscopic polyangiitis, and it is also positive in Churg-Strauss syndrome, and it is positive in case of the inflammatory bowel disease, but not in case of membranous glomerulonephritis. And next one is anti-dsDNA. Anti-dsDNA, it is positive in case of lupus nephritis secondary to your SLE, but not in membranous glomerulonephritis. Anti-glomerular basement membrane antibody, it is positive in case of Wood-Pasteur syndrome, but not in case of membranous glomerulonephritis. So the answer is second option. Then we have a 12-year-old boy presents with periodontal edema, cola-colored urine, hypertension after sore throat 2 weeks ago. Urine shows RBC cast and protein of 2+. Labs, there will be low C3 and normal C4 and ASO titer is elevated. What is the most characteristic finding on the electron microscopy? So this individual is having a nephritic range proteinuria because protein is like 2+. And complement is reduced, but C4 levels are normal. ASO titer is elevated. So what is this suggestive of post-streptococcal glomerulonephritis? So what is the electron microscopic finding? Linear IgG deposition along glomerular basement membrane, subepithelial deposits with duplication of glomerular basement membrane, subepithelial hump-shaped deposits, then mesangial electron-dense deposits. So in case of post-streptococcal glomerulonephritis, you will notice that there will be subepithelial hump-shaped deposits. That is a feature in case of post-streptococcal glomerulonephritis. And the immunofluorescence in case of post-streptococcal glomerulonephritis, this will give you the characteristic starry sky appearance, whereas electron microscopy will show you that there is presence of subepithelial humps and the complement level will be reduced, but will be transient hypocomplementemia in patients with post-streptococcal glomerulonephritis. After few weeks, the complement level will return back to normal. Then linear IgG deposition along glomerular basement membrane, that is present in case of Wood-Pasteur syndrome. Subepithelial deposits with duplication of the glomerular basement membrane. This is observed in case of membranoproliferative glomerulonephritis type 1. So this will give you a tram track appearance. Then mesangial electron-dense deposits, that is observed in case of the IgA nephropathy, but not in case of post-streptococcal glomerulonephritis. So the answer here is C. Next question. We have a 22-year-old man presenting with gross hematuria 1 to 2 days after upper respiratory infection. The urine shows the RBC's mild proteinuria of a range of 1.2 grams per day. Serum complement levels are normal. And what is the most likely diagnosis? The options are post-streptococcal glomerulonephritis, lupus nephritis, MPGN type 1 and IgA nephropathy. So the individual is having gross hematuria. That is first point. 1 to 2 days after the upper respiratory infection, and complement levels are normal, and there is mild proteinuria. So all these are suggestive of the IgA nephropathy, right? So hematuria, here it is coinciding with the mucosal infection. Normal complement level will rule out the post-streptococcal glomerulonephritis. And immunofluorescence will show you a mesangial IgA deposition in case of the IgA nephropathy, right? Whereas you take in case of the lupus nephritis. In lupus nephritis also, there will be low C3 and as well as low C4. But the question says that C3 is normal. And you take membranoproliferative glomerulonephritis type 1, these patients also, they have low complement and they have a chronic course with nephritic and as well as nephrotic features. So these patients with membranoproliferative glomerulonephritis type 1, they'll have both nephritic and as well as nephrotic features. So the answer in this question is the IgA nephropathy, right? So if you see the next question, we have a 25-year-old woman with SLE presents with proteinuria of 4.2 grams per day. RBC casts are present and there is also elevated dsDNA titer. Complement levels are reduced and wire loop thickening of the capillary loops are being present. And which class of the lupus nephritis does this patient belong to? Class 2, mesangial proliferative, class 3, focal proliferative, class 4, diffuse proliferative, class 5, membranous nephritis. So, presence of this wire loop lesions, they are characteristic of the class 4, that is diffuse lupus nephritis. So, in case of this diffuse lupus nephritis, more than 50% glomeruli are being affected. Right, more than 50% glomeruli are being affected with subendothelial deposits, and that will give you the wire loop appearance. And this diffuse lupus nephritis, this is the most common and a severe form of the lupus nephritis as well. Whereas you take class 2, mesangial proliferative, in these patients there will be mesangial hypercellularity and mesangial immune deposits as well. And in case of the focal proliferative, less than 50% of the glomeruli are involved. In diffuse, more than 50% glomeruli are involved. Whereas in class 5, that is membranous, you will have subepithelial deposits and causing nephrotic range proteinuria. So this is about the lupus nephritis. Next question, we have a 50-year-old man develops rapid renal failure with hematuria and RBC cast. Biopsy shows the presence of crescents in Bowman space. The immunofluorescence shows linear IgG deposition along the glomerular basement membrane. Which of the following is the best diagnosis? The options are membranous nephropathy, pauci-immune glomerulonephritis, anti-glomerular basement membrane disease, the immune complex glomerulonephritis. So this individual is having rapid renal failure, hematuria and RBC cast. And there is linear IgG deposition along the glomerular basement membrane. So this is suggestive of the Goodpasture syndrome. So what is this? It is anti-glomerular basement membrane disease, that is Goodpasture syndrome, and these patients will be having antibody formation against the glomerular basement membrane and alveolar basement membrane. That is why they present with hematuria and as well as hemoptysis. These patients with the Goodpasture syndrome, they have to undergo plasmapheresis initially. Followed by that, they will be requiring corticosteroids and as well as azathioprine to prevent the new antibody formation. Whereas in membranous nephropathy, the microscopy will show you spike and dome appearance. Whereas in ANCA-associated glomerulonephritis, you don't have immunofluorescent deposition at all and there is no linear IgG also. And immune complex glomerulonephritis, you will have this lumpy, bumpy immunofluorescent appearance. So that is what you will observe in case of immune complex glomerulonephritis. Next question. 17-year-old girl with proteinuria, hematuria and low complement levels having a biopsy showing tram-track glomerular basement membrane with mesangial interposition. The C3 levels, immunofluorescence shows only C3, no IgG. What is the most likely subtype? So here the options are lupus nephritis, dense deposit disease, that is C3 glomerulopathy, then FSGS, immune complex mediated membranoproliferative glomerulonephritis type 1. So the tram-track glomerular basement membrane with mesangial interposition, that is observed in case of dense deposit disease, that is C3 glomerulopathy, right? So this C3 glomerulopathy is caused by complement dysregulation, right? It is caused by complement dysregulation where you will have only C3 nephritic factor. So these patients will have only C3 and electron microscopy shows dense ribbon-like deposits. Electron microscopy shows dense ribbon-like deposits, okay? And in case of the lupus nephritis, you will have the full house immunofluorescence IgG will be there, IgA will be there, IgM will be there, C3 and C1q will be there. Not C3 only in case of lupus nephritis. And in C3 glomerulopathy, you'll have only C3, whereas in focal segmental glomerulosclerosis, you'll have segmental sclerosis. You don't have tram track appearance in case of FSGS. Next one is immune complex mediated membranoproliferative glomerulonephritis type 1. So here you will have classically IgG plus C3 granular deposits will be there. So this is about the dense deposit disease, that is C3 glomerulopathy. Next question. So we have a 56-year-old man with type 2 diabetes mellitus for 12 years presenting with the microalbuminuria and normal creatinine. What is the first structural change in the kidney in diabetic nephropathy? The options are nodular chemical steel lesion. It is pathognomic for diabetes, but that is not earliest. Arterial hyalinosis, glomerular basement membrane thickening, and then glomerulosclerosis. So what is that you will observe in case of diabetic nephropathy? In diabetic nephropathy, you will have the earliest as the glomerular basement membrane thickening, right? So that is the earliest what you see in case of the diabetes. Then what are the other lesions that if you observe? So earliest structural change is glomerular basement membrane thickening. And these patients, because of the mesangial expansion, they'll have this nodular sclerosis that is called KW lesion, which is pathognomic for tuberculosis. Next is microalbuminuria. This microalbuminuria is the earliest functional marker in case of diabetic nephropathy. So the answer in this question is glomerular basement membrane thickening, which is the earliest. Next question. We have a 62-year-old man with chronic inflammatory arthritis and they develop massive proteinuria nephrotic syndrome. Renal biopsy shows amorphous eosinophilic deposits in the mesangium, apple green birefringence under the polarized light. Which protein is most likely responsible? AL type of amyloid, transthyretin ATTR, then beta-2 microglobulin, and then serum amyloid A. So here it is the amyloidosis secondary to renal pathology. So we consider this as the A type of amyloidosis. This A type of amyloidosis is nothing but secondary amyloidosis. And why does they occur? That is due to chronic inflammatory states. Whereas AL type of amyloidosis is a primary amyloidosis, where you have plasma churning, where you see this AL type of amyloidosis in case of plasma cell dyscrasias like multiple myeloma. Then beta-2 microglobulin. Beta-2 microglobulin, it is dialysis related amyloid. And what about ATTR, that is transthyretin? ATTR, it is hereditary or wild type. In case of ATTR, you will have the cardiac or neurological manifestations, right? You will have cardiac and as well as neurological manifestations. So cardiac amyloid or neuropathy amyloid. Renal involvement is less, right? Renal involvement is less in case of the ATTR type of the amyloidosis, right? Next question. We have a 63-year-old man with refractory hypertension and abdominal bruit is started, right? Abdominal bruit is being present. And this individual is started on lisinopril, and that is ACE inhibitor. Within 3 days, his serum creatinine has increased from 1.2 to 2.9. Urine analysis is bland, no hematuria or proteinuria. What is the most likely diagnosis? Acute tubular necrosis, bilateral renal artery stenosis, atherosclerotic disease, and acute interstitial nephritis. So, in which clinical scenario your creatinine increases after starting ACE inhibitor? Among the options which has been given to you is bilateral renal artery stenosis. So, in bilateral renal artery stenosis, the ACE inhibitors, they are contraindicated. They worsen the underlying renal injury. That is the reason why ACE inhibitors are contraindicated. Whereas, in which conditions you can give ACE inhibitors? ACE inhibitors can be given in case of unilateral renal artery stenosis, but not in case of bilateral renal artery stenosis, right? So here, like the increase in serum creatinine after starting ACE inhibitor, because what these ACE inhibitors will do in case of bilateral renal artery stenosis, they decrease the GFR, right? They decrease the GFR in both kidneys and depending on the angiotensin too. So the clue is that there is more than 30% creatinine rise after ACE inhibitor or ARBs. That is suggestive of the bilateral renal artery stenosis. And whereas you take acute tubular necrosis, what does it show? It will show you a muddy brown granular cast and FeNA will be more than 2%, right? And this ischemia or necrosis is not precipitated by your ACE inhibitor. So your acute tubular necrosis is ruled out. In cases of atherosclerotic renal disease, these patients will be having eosinophilia. they'll be having livedo reticularis and they'll be having the retinal plaques which are absent in this patient, so atherosclerotic disease is ruled out. Then acute interstitial nephritis. These patients, they present with a triad. And what will be the triad? They'll have fever, rash, and along with that, you will notice that there is increase in the eosinophils, which is not there in this patient. So your acute interstitial nephritis is ruled out. Next question. We have a 30-year-old woman presenting with severe hypertension where the blood pressure is 180 by 110. Examination reveals an abdominal bruit but no renal dysfunction. And CT angiography shows string of beads appearance on the renal artery. Which of the following statement is true? The first option, it presents with proteinuria and microhematuria. It is due to medial fibroplasia of the renal artery. It usually progresses to end-stage renal disease despite the treatment. It occurs exclusively in the elderly diabetics. So, presence of string of beads appearance. This is suggestive of, right? This is suggestive of the fibromuscular dysplasia. What is this fibromuscular dysplasia? This is one of the cause for renal artery stenosis. And this individual, because of the renal artery stenosis, is having a bruit. So what is the answer here? So this is due to medial fibroplasia of the renal artery. So this fibromuscular dysplasia, it is a non-atherosclerotic, non-inflammatory renal artery stenosis, very common in young individuals. And why is this specific string of bead appearance? This is because of alternating stenosis and as well as dilatation. And how do you treat these patients is, we don't give ACE inhibitors, we need to place a stent, that is PTRA, that is percutaneous transluminal renal angioplasty, right? We need to place a stent. So the answer is, it is due to medial fibroplasia of the renal artery. Next question. A 74-year-old man undergoing coronary angiography, 2 weeks later he develops worsening renal function, livedo reticularis and eosinophilia. Urine analysis shows few RBCs and no protein. What is the most likely cause? Cholesterol crystal embolizing from the aortic plaques, the contrast-induced nephropathy, renal infarction and vasculitis, that is polyarteritis nodosa. So, atherosclerotic disease, it occurs post-instrumentation and the skin showing livedo reticularis and blutose and blood showing eosinophilia, that is classically suggestive of atherosclerotic diseases. So, it is cholesterol crystal embolization from the aortic plaque. So, when you do a biopsy in these patients with the atherosclerotic disease, you will notice a biconvex, right? You will notice a biconvex needle-shaped clefts, right? Biconvex needle-shaped clefts in arterioles, right? Biconvex needle-shaped clefts in arterioles. So that is what you'll observe. So cholesterol crystal embolization from aortic plaques is like the picture what has been observed, right? Where the skin findings are livedo reticularis, blutose, and there is also eosinophilia, right? Next question. A 35-year-old woman with nephrolithiasis presents with fatigue and as well as muscle weakness. Potassium is 2.8. Bicarbonate is 14 milliequivalents per liter. Urine shows pH of more than 6. Positive urine anion gap. What is the most likely diagnosis in this patient? Type 1 renal tubular acidosis, chronic diarrhea with metabolic acidosis, type 4 renal tubular acidosis and type 2 renal tubular acidosis. So, this individual is having bicarbonate of 14, which is suggestive of the metabolic acidosis, right? And urine anion gap being positive and urine pH more than 6, this is suggestive of renal tubular acidosis. And in which type of renal tubular acidosis you will have nephrolithiasis and along with that having hypokalemia, that is observed in case of type 1 renal tubular acidosis, right? Whereas in type 2 renal tubular acidosis, how is it ruled out? Type 2 renal tubular acidosis, it is ruled out by the pH, where the pH is less than 5.5. Which pH? The urine pH. Urine pH will be less than 5.5 in case of a type 2 renal tubular acidosis, right? And in case of type 4, you don't have nephrolithiasis, renal stone formation will not be there. So that is the reason why the answer is A in this question. So next question, if you see, a 10-year-old boy has polyuria, bone pain and growth retardation. Labs show bicarbonate of 15 milliequivalents per liter, potassium 3 milliequivalents per liter, phosphate 1.8 and there is glycosuria without hyperglycemia. What is the most likely diagnosis in this patient? So this patient is carbonic anhydrase inhibitor overdose, distal renal tubular acidosis due to Sjogren's, Fanconi syndrome causing proximal renal tubular acidosis, type 4 renal tubular acidosis from the hypoaldosteronism. So this patient is having polyuria, there is also bone pain, and there is also growth retardation. Bicarbonate is less acidotic. Hypokalemia is there, and glycosuria without hyperglycemia. So all these are the features suggestive of your type 2 renal tubular acidosis, which is nothing but Fanconi's. In case of Fanconi's, the pathology is at the level of proximal convoluted tubule. So there is no 1-alpha hydroxylase, no vitamin D, so growth retardation. And there is also bone pain because there is hypocalcemia. And water reabsorption will not be there because there is injury to the PCT or problem in the PCT. That is the reason why there is polyuria. Bicarbonate is not reabsorbed, so the bicarbonate levels are reduced. And the next important is the phosphate is not reabsorbed and glucose is also not reabsorbed at the level of PCT because the problem is at the level of PCT. That is the reason why phosphate is low and glycosuria is also there in this individual. So this picture is suggestive of the Fanconi syndrome causing proximal renal tubular acidosis. Next question. We have a 60-year-old diabetic man presenting with hyperkalemia and mild metabolic acidosis. Urine pH is like 5.2 and no ketones. The serum renin and aldosterone is low, and what is the underlying mechanism? Increased chloride excretion, bicarbonate loss from PCT, hypoaldosteronism leading to impaired distal sodium-potassium exchange, impaired ammonia trapping due to low glomerular filtration rate. So this patient is having hyperkalemia, bicarbonate is reduced, and urine pH is less than 5.5 and the aldosterone is low. So that is suggestive of the hypoaldosteronism leading to impaired distal sodium-potassium exchange. So this is your type 4 renal tubular acidosis. In type 4 renal tubular acidosis, there is aldosterone resistance or there is deficiency of the aldosterone. That is what is causing acidosis and as well as the hyperkalemia in these patients, right? And how will you tell it is type 4? Because there is hyperkalemia and aldosterone levels are low, which comes under your type 4. And this particular type 4, the most common cause for type 4 will be the diabetes mellitus. Next question. We have a 42-year-old man presenting with flank fullness and hypertension. Ultrasound shows bilateral enlarged cystic kidneys. Family history, mother died of subarachnoid hemorrhage. Which of the following extrarenal feature is classically associated in this patient? The sensory neural deafness, berry-aneurysm of circle of Willis, then lung cyst and pneumothorax, and retinal angiomas. So this patient, if you observe closely, is having polycystic kidney disease and 42-year-old individual. So adult polycystic kidney disease, the type of inheritance is autosomal dominant type of inheritance. And in patients with polycystic kidney disease, you will not only have renal, extrarenal manifestations are also very common. The cyst can be present in other sites like liver, ovary and pancreas. The CNS manifestations can be there in the form of subarachnoid hemorrhage and as well as arterial dolichoectasias. Then GIT manifestations will be in the form of like gastrointestinal polyps, and cardiovascular manifestation will be in the form of mitral valve prolapse syndrome and tricuspid regurgitation. So the extrarenal anomaly that you can observe in these individuals is because their mother died of subarachnoid hemorrhage. What is the cause of subarachnoid hemorrhage in a patient with polycystic kidney disease? That is rupture of berry aneurysm, which is originating from circle of Willis. Right? Rupture of berry aneurysm, which is originating from the circle of Willis. Okay. So this is about the polycystic kidney disease. And what about sensory neural hearing loss? Sensory neural hearing loss is a feature of Alport syndrome along with kidney injury, but not in case of polycystic kidney disease. And lung cyst and as well as pneumothorax, this is the feature of LAM. What is this LAM? Lymphoangioleiomyomatosis. There in LAM, you will have lung cyst and as well as pneumothorax. Then retinal angiomas. Retinal angiomas, they are observed in case of von Hippel-Lindau disease, but not in case of ADPKD. So the answer here is berry aneurysm of the circle of Willis. And the next question. We have a 20-year-old man presenting with microscopic hematuria, sensory neural hearing loss. There is anterior lenticonus. Family history, there are multiple males with renal failure in early adulthood. Which mutation is most likely responsible? So there is microscopic hematuria, sensory neural hearing loss and anterior lenticonus. So all these are the points which are suggestive of the Alport syndrome. Right, which are suggestive of the Alport syndrome. So in case of Alport syndrome, what is the gene that is being mutated? That is COL4A5 gene is being mutated in this individual. And this Alport's, it is an X-linked disorder and the defect is in the type 4 collagen. The defect is in type 4 collagen. It's a type 4 collagen defect, right? And the electron microscopy will show that there is glomerular basement membrane splitting, and that is giving you a basket view appearance. And ocular manifestation will be anterior lenticonus, and perimacular flex will be there in these patients with the Alports. And what about this PKHD1 gene? That is mutated in case of autosomal recessive polycystic kidney disease. And WT1 gene mutation is observed in case of a particular syndrome called as WAGR syndrome. Then next is PAX2 gene mutation. PAX2 gene mutation is observed in case of renal coloboma syndrome, right? Renal coloboma syndrome. So this is about the various genes and as well as mutations. And in case of Alports, it is called 4A5 gene is being mutated, and it is X-linked inheritance. Next question. We have a 26-year-old man having the episodic severe burning pain in the hands and feet. There is also angiokeratomas and corneal opacities. He later develops proteinuria and left ventricular hypertrophy. Which enzyme is deficient? Glucose 6-phosphatase, cystinosin, beta-glucocerebrosidase, alpha-galactosidase A. So, what is this clinical picture suggestive of? The presence of burning pain in the hands and feet, angiokeratomas and corneal opacities. So, all these are the features suggestive of Fabry's disease. And this Fabry's, it is an X-linked disease. And in these patients with Fabry's, what is being built up? It is GB3, that is globotriosylceramide, right? Globotriosylceramide is being built up. And what are the organs affected here? You have the involvement of the kidney, heart, nerves and skin. And what is the treatment that you need to give? You need to give the enzymatic replacement therapy. And what is the enzyme that is being defective in these individuals? That is alpha-galactosidase A is being deficient. Whereas glucose 6-phosphatase is deficient in case of von Gehr's disease. Cystinosin, right? It is a nephropathic cystinosis. And the beta-glucocerebrosidase, that is deficient in case of the Gaucher's disease, right? So this is about the alpha-galactosidase A deficiency, that is Fabry's. Next question. 24-year-old women presenting with muscle cramps and weakness, labs potassium 2.9, bicarbonate 30, normal blood pressure, urine chloride high, magnesium normal, calcium excretion high. What is the diagnosis? Liddle syndrome, it is ruled out because these patients will be having hypertension. And hyperaldosteronism, that is also ruled out because these patients also will be having diastolic hypertension. And Gittelman's and as well as Barter's, these two are your close differentials. You take in case of Barter's, what is, see, actually the answer in this question is the Barter syndrome, not Gittelman's. Why? So, if you see the picture, in case of Barter's, the defect is in NKCC2 defect, that is in loop of Henle. And these patients will be having metabolic alkalosis, hypokalemia and as well as hypercalciuria. Whereas in case of Gittelman's, it is NCC defect, that is in the distal connector tubule. These patients will be presenting with hypocalciuria and as well as the hypomagnesemia, right? But this question says magnesium is normal. So that will rule out your Gittelman's. So what is the picture suggestive of? So in this question, the answer is the Barter syndrome. So these are the questions related to nephrology. Thank you very much.